welcome to another edition of the CTSNet podcast. My name's Joel Dunning, and today we have an extremely special edition for you. We have all the usual things. We've got some of our fabulous content, including 3 great videos. We've got an interview with Vinck about lung transplantation in Colombia. We've got a really good, nice, fast video about a left atrial myxoma, minimally invasive resection with 3D vision. And we've got a fabulous session from the SCTS all about coronary revascularization. But the biggest thing in this video we have, it's all about the massive new guidelines that have just come out jointly with the AHA and many others, all about revascularization. So stick around, let's get into this edition of the CTSNet Beat podcast. So the massive news this week is the publication of actually not 1 but 2 enormous guidelines, and these are must-reads. You cannot do cardiac practice without knowing these new guidelines. So the first one is called the Guideline for the Management of Patients with Chronic Coronary Disease, a report of the AHA, the American College of Cardiology, Joint Committees on Clinical Practice Guidelines. Who was involved in this? The AHA, the ACC, the ACCP, the ASPC, the NLA, the PCNA, everybody. And this is the first update for a decade as well. These 2023 guidelines were last written in over a decade ago, so I believe 2011. So they really are big, and they are going to be the guidelines that you will be referencing from evermore in your heart team approaches. So we're going to get a big deep dive into these. Now, interestingly, there's also been another guideline out as well, the AHA ACC Clinical Performance and Quality Measures for Coronary Artery Revasc, all at the same time on the AHA journals. So check out the links that we're providing below. But we are going to have a very special discussion here on the CTSNet podcast. I'm delighted to be joined by Faisal Bakaeen. I've just had a really good chat to him about these guidelines. Faisal probably is known to most of you. He's an amazing cardiac surgeon at the Cleveland Clinic, and he's also been the chairman of the STS Guidelines Committee. He was actually one of the committee members on the Coronary Artery Revasc Quality Measures Guideline Group, and we talked to him all about these new guidelines. So thank you to Faisal. Let's listen to our conversation we've just had with him about these new guidelines. Hello, Faisal Bakaeen. It's so good to see you again. We've worked together, and it's an absolute pleasure to have you here. You're massively known in the STS and the AATS, but for those of you who don't know Faisal, he's a professor of surgery at the Cleveland Clinic. He's got a special interest in revascularization. He's been chairman of the STS Guidelines Committee. He's been involved in the AATS Clinical Practice and Standards Committee. He is Mr. Guidelines and Mr. Revascularization. So it's a real pleasure to have you here. And the real reason we've got you here is because of the brand new publication, the 2023 AHA ACC Guidelines for the Management of Patients with Chronic Coronary Disease. And these are big, these are massive. These are the recommendations that we need to follow in our heart team approach guiding revascularization. So I maybe would love to just hear from you, first of all, what their sort of highlight recommendations are in this new guideline, particularly with regard to revascularization. And then we'll talk about how they came to make these decisions.
Joe, first of all, thank you very much. Does my head still fit into the screen after all the good things that you said about me? That was very kind. We follow your lead about critical thinking and innovation, and we're really proud of our relationship with you. I mean, over the years, we worked together, and I really appreciate that collegiality, friendship, and your expertise and collaborative approach and scientific acumen is also very renowned. So it's an absolute pleasure to be with you today and to be with our audience. I know you've got a really fantastic and diverse audience. So I'm going to try and be basic, but also take it a little deeper into the details. So these are my own opinions, by the way. Everything that I say today reflects my own personal opinion. So please bear that in mind. With regards to the 2023 chronic coronary disease patient management guidelines, the surgical community was disappointed. The document itself had some really excellent content, virtually in everything related to stable coronary artery disease, except the section on revascularization. So we have to be clear. about that. And why do we have a problem with the revascularization section? Well, because it was a replica of the 2021 ACCHA SKY guidelines on revascularization. And in it, CABG was downgraded without meaningful evidence, without relevant evidence. And what they did was downgrade CABG in patients with normal left ventricular function and in patients with mild to moderate LV dysfunction relative to medical therapy with survival as an endpoint. So CABG remained the class 1 in patients with multi-vessel disease and severe LV dysfunction, but in those with normal function, it dropped to class 2B, and those with mild to moderate dysfunction, it dropped to class 2A. So that is the downgrade that, I mean, there are other issues as well, but that is the downgrade that really was unexpected and unjustified. They also equated CABG with PCI when it came to MACE, and we know that those two modalities are totally different. They're actually complementary rather than competing, but we can address that later on if we have time, but we should focus perhaps on the downgrade for survival relative to medical therapy.
Yeah, and maybe say a few words about that evidence. I mean, we've got the Syntax trial, we've got 10-year follow-up of Syntax, we've got Stuart Head did an amazing meta-analysis of several studies showing the superiority of CABG over PCI in these patients. I mean, are you convinced, like I am, that this is grade 1 evidence of CABG superiority over PCI?
Well, you know, that issue, actually, I'm glad you mentioned that. Relative to PCI, the 2021 guidelines have given the upper hand for CABG in patients with 3-vessel disease that is complex, especially with a higher Syntax score. So that's not an issue of controversy. They acknowledge that, and that is consistent in the 2023 recommendations. So our argument was, if you're saying that CABG is superior to PCI in survival, regardless of the EF in patients with 3-vessel disease, how could it be of questionable benefit compared to medical therapy? So that's one of the, if you'd like, schizophrenic aspect of the guidelines. I mean, unless you're insinuating that PCI is harmful, and there's no study that was ever published to confirm that PCI is harmful compared to medical therapy. So with regards to the evidence specifically between CABG and medical therapy, the evidence that we have in randomized patients between medical therapy and CABG is the Salim Youssef meta-analysis that clearly demonstrated survival advantage for CABG, regardless of the EF, and the European study, which again demonstrated the same, even in patients with 2-vessel disease and proximal LAD. But the guideline committee said, oh, these are old studies. Medical therapy got better. And we said, yeah, we agree. That's why all our patients, we'd like them to be on optimal medical therapy. And if you look at CABG has improved as well. And we bring to their attention that in the Salim Youssef meta-analysis in the 90s, the 30-day mortality of CABG was 3%. In the FAME-3 study that got published recently, the 30-day mortality of CABG was 3 in 1,000. So CABG perioperative mortality decreased by a factor of 10. So did medical therapy improve by a factor of 10? I doubt it. So the idea of those studies are old and that medical therapy is better, they need to actually acknowledge that CABG got better as well. So then they say, well, we're going to present you with new evidence. Well, that's where the problem is. The new evidence really is not relevant to CABG versus medical therapy. Why? Because the ischemia study, which is the main study, the cornerstone of their downgrade, did not randomize a single patient to CABG or PCI for that matter. It was a strategy whereby you use a conservative approach where you just treat them medically, or you do a diagnostic cath, and then based on the diagnostic cath, you could decide if you want to revascularize or not. So not a single patient was randomized to CABG. Secondly, only less than 25% of patients had CABG. 3/4 of the interventions were actually PCI. And finally, how many people you think had severe proximal LA disease? Very little, 36% actually had greater than 50% proximal LAD disease. I can't remember the last time that I did a CABG on a patient without a significant proximal LAD lesion. So clearly ischemia, nor the meta-analysis that they cite are based on randomized evidence in which CABG is adequately represented and in which the complexity of and the atherosclerotic burden of those patients are taken into consideration. Because if you look at the STS database, you find that many more of them are diabetic compared to the ischemia population. And you find that 2 to 4 times the STS patients are more likely to have severe peripheral vascular disease, cerebral vascular disease, or heart failure compared to the ischemia patients.
You just heard a portion of Joel's interview with Faisal Bakaeen. The full interview and transcript will be available on CTSNet early next week.
Thank you once again, Faisal, for a really fascinating insight on these must-read guidelines from the AHA. So what else is there on CTSNet this week, if that wasn't enough for you? Well, we've chosen 3 really great videos for you. The first one's just a really nice, quick 13-minute video that our own fabulous Emily Farkas did at the AATS with a guy called Vinck. He's a fabulous trainee cardiac surgeon, but he's in Colombia. He's had a really interesting training because it's all been in Colombia. He's actually the first trainee that's fully trained in Colombia for lung transplantation, and he gives some really interesting insights as to where they are with lung transplantation. It's small volume, it's a low number of centres, but actually does point out that Colombia and Brazil are the only centres in South America performing lung transplant. Really difficult, but really great interview. Well done, Emily Farkas. Brilliant interview, really smooth, nice and quick, just 13 minutes, so check it out on our front page today. The second video we've got for you is a real quick one. It's a really nice video by German Fortunato and Vadim Kotowitz from Buenos Aires. And in Buenos Aires, they perform minimally invasive mitral surgery, and they came along with a myxoma. So they do a right anterior thoracotomy, they use peripheral cannulation, but the thing that they're demonstrating in this super quick 5-minute video is that they use 3D endoscopic cameras to get that 3D vision into the left atrium, making the resection of this huge left atrial myxoma much easier and more simple for them. So really nice job. It goes through it in really good detail. It's really very quick. So just have a quick nose at that if you just got 5 minutes and let me know what you think. What do you think about 3D vision in minimally invasive surgery? Is it good? Is it not? Obviously, robotics always gives you 3D vision without you actually having to leave the table. So some people call this a really good hybrid between what standard minimally invasive surgery gives you and robotics. So maybe 3D vision is a real key for you. I also find that actually 3D is vital for suturing, which is obviously mandatory in mitral surgery and port access. So maybe port access mitral surgery with a 3D camera is the answer for minimally invasive surgery rather than a robot. What do you think? Give us some comments in the notes below. The third video we've got for you is absolutely fantastic. If you are interested in coronary revascularization, and today is a bit of a coronary revasc mega fest, isn't it? Then we've got the Society of Cardiothoracic Surgery UK conference full session on coronary. It was their expert university session, so this is 1 hour and 33 minutes of the best people in coronary revasc, giving you everything you want to know about coronary revascularization. So the first talk was on technical tips on arterial harvesting, on Lima and Riva skeletonization by Dr. Bala from Stoke. Great job, really nice. Got some good videos there. The second one was from Vipin Zamvar. He gave the 10 top tips for off-pump surgery and really nice videos, really good top tips, all about getting amazing mobilization, really open the pericardium. Where do You put that stitch at the back, and a really nice one there. Then the SCTS attracts really international top stellar people, and Piroz Daravawala from Toronto came over and gave a great presentation on minimally invasive coronary artery surgery, which is his routine in Toronto. I thought that was a fantastic session. And then there's a really good session by Miles Behan on fractional flow reserve, using this in coronary surgery. Arterial revascularization by Sarzad Raja. And the amazing John Puskas gave a great talk on transit time flow measurement, how to measure the flow after your grafts, and should everyone be doing it. And finally, the one and only Gianni Angelini from Bristol gave us a good talk all about vein grafts in contemporary practice. So I thought that was an absolutely brilliant session, total banger. If you do a lot of our bread and butter, which is coronary revasc, you really have to watch that. Which was brilliant. So, upcoming events. We've got quite a few for you. It's the summer holidays, but very soon we'll be into conference season in September and October. So right at the start of September, there's going to be a really interesting mitral valve repair Drylab training in Maastricht in the Netherlands. So everything you want to know about port access mitral. There's going to be simulated physical models set up. You can try everything you like. So click on the show notes below if you're interested, and available at the start of September. We better mention some thoracic surgery, and there's a segmentectomy webinar coming up in EACTS Thursday, the September the 7th. It's online, it's virtual, and it's free. So if you want to go to the EACTS website, log on there, and then you will get an hour of everything that's fantastic about segmentectomy, nice and free. So do check that out. And our third thing we're going to profile today is current paradigms in interventional pulmonology, EBUS, advanced bronchoscopy in the area of robotics and ion, intuitive bronchoscope, Monarch, everything that's new. This is in the Zuckerman Research Center in New York, Friday, this September the 8th, and it's hybrid. It can be online, virtual, or in person. So if you like the sound of that, it is going to be the future of a lot of lung cancer treatment, so check that out. And finally, we always find out where Diego Gonzalez Rivas is, the world's roving thoracic surgery. And this week he flew over to the Azores. He performed 4 operations at the San Miguel Hospital, doing uniportal VATS, and then he went surfing. I'm sure he deserves a bit of a break after his huge world tour, so well done to him. And we always give an honourable mention to somebody that we think is just worth it, and this week has been such a coronary revasc session on the podcast that we have to really acknowledge John D. Puskas. He really is the current godfather of everything revascularization. He's at the Mount Sinai Hospital, but he's had 25 years of coronary revascularization. He's done 5,000 off-pump operations. He's done 500 robotic revascularizations. He's led many of the biggest trials in revascularization. He's currently doing a brilliant NIHR revas trial in hybrid coronary artery surgery and stenting. And he's a founding member of ISMICS, and I probably haven't mentioned a quarter of the things. He's also a wonderful guy. I had a great opportunity to interview him as a giant of cardiothoracic surgery many years ago. He's very generous with his time. Wonderful guy, John D. Puskas. You are our honourable mention this week, and a fantastic guy. So that's it for this week. Tune in next week. We'll give you more of everything that's big and fantastic in cardiothoracic surgery. So for myself, Joel Dunning, and everyone at the team at CTSNet, thanks for watching all the way to the end, and see you next week.